So we all know that pediatric endocrinology is often considered a rare disorder which is complicated, requiring cumbersome workup and exorbitant treatments. And that's why often disorders of pediatric endocrinology are either missed or missed. And there are a lot of issues in terms of pediatric endocrinology that people tend to blame. One people talk about is affordability, that these are very expensive investigations. Doctors are not available, but actually it's the awareness which is the major factor. So if we really empower people, both the pediatricians, the trainees, as well as the general public, they will get to the doctor at the right time and they will identify. That's what we found, that awareness is the key from that regards. In a country like India, where there is a huge burden of pediatric endocrine disorders, we have got very limited number of pediatric endocrinologists which are there. So there is a need to build a pyramidal approach in which we have got referral across board, in which cases are managed and triaged appropriately. And that's why this development of pediatric endocrine resource is extremely important. We have been working over the last 15 years in different aspects of pediatric endocrinology, and we have conducted over 120 workshops, 15 practical courses, two postgraduate programs, and multiple advanced courses across the country. But then what we realized that it was going to be very difficult from that perspective to work off. I'll request everybody to mute themselves, please. So we have been working in different aspects. So we realized that it's going to be very difficult to have physical program across the different parts. So we started off with our YouTube channel, in which we have published a number of videos which are easily available, and a lot of views have been done in that regards. Over the last 8 years, we have had fellowship programs which are there. Now we have 14 fellows till date who are there as part of our program. And many of them will be joining us. Dr. Neha, Dr. Chetan, Dr. Riddhi, Prateek, Manoj, Vibha, Dhwani, Alapan, Nimisha, Riya, all of them will be part of this program. So there are few who are busy who couldn't join, but otherwise most of them will be part of the program. Because it's difficult to have physical fellowship programs for everybody, we started off with MedEClasses, which provides online resources in terms of pediatric endocrinology, including fellowship, diploma, and multiple courses. Our fellowship program is a 2-year program in which we have online and 4 on-site visits with routine assessments and options for research. Till now, 48 people have been awarded fellowships, and 72, and now the numbers have gone up, are continuing that from different parts of the world from that perspective. We've got multiple publications in pediatric endocrinology. Our mobile application, which we'll discuss about, provides a practical way of enhancing pediatric endocrine care. It's the most downloaded endocrinology app across platforms, and it has resulted in multiple publications in that perspective. We are going to launch BIG, which is bone age assisted interpretation of growth, very soon in the next month, which is going to provide direct assessment of growth, puberty, obesity, and multiple parameters on the entry of a few parameters, and you will get interpretation and likely diagnosis and assessment management from that regards. We are also working on developing personalized intelligent nutrition, which is going to guide us in terms of the nutritional requirement, assess meals, and plan based upon intelligent pathway. Our diabetes application is going to provide point of care guidance to insulin dose, glucose, activity, sleep right, and eat in terms of pediatric type 1 diabetes patients. And this is under clinical trials at the moment, and hopefully this is going to change the way diabetes is managed from that perspective. So coming back to this course, this is an extensive course, and this day is to basically dedicated to office endocrinology.
The functions are the most commonly prescribed by most of the pediatricians and pediatric endocrinologists. So the most important hormone in the thyroid pituitary hypothalamic pituitary thyroid axis is the TRH, which is secreted by the hypothalamus and which acts on the TRH receptor in the pituitary and regulates the secretion of TSH. Now, this TSH further acts on the thyroid gland and on the thyroid receptor to produce the T4 and the T3. T4 is the prohormone, which is converted to the T3 by the immunodiabinase activity 1. And these both the T3 and T4 circulates in the blood bounding to the TBG. So only the free T4, that is around 0.03% in the FT4 and 0.3% of the FT3, which acts on the tissue and which regulates the function of the body. So And this FT3, which is the most important and the active hormone, acts on the thyroid receptors in different parts of the body. Talking about the primary hypothyroidism, in this condition, the main hormone to go up is the increase in the TSH. After that, it is followed by decrease in the free T4 or the T4. And in the last, body tries to convert this, maintain the level of the T3 by activating the MDI3. So the T3 is the last hormone to fall down. So if we ask the most common and the most ideal test to be done in the primary hypothyroidism, it is the TSH and the free T4. And if we talk about the central hypothyroidism, in this condition, the free T4 goes down, but in this, the TSH does not goes as high as it increases in the primary hypothyroidism due to the presence of bioinactive TSH. So TSH either remains the normal or it increases up to 10 or 20 units. In case of the thyrotoxicosis, where there is an increased production of the thyroid hormone, the first hormone to goes down is the TSH, and further, the T3 is the second hormone which increases in the level, then followed by the T4. So, it is important to know what is the thyroid function test, when it should be done, and how it should be done. So, in case of hypothyroidism, where the TSH is the first hormone to increase, the T4 goes down because it plays a log linear relationship where the TSH increases, it causes the fall in T4, and T3 is the last hormone to goes down. So in hypothyroidism, FT4 and TSH should be prescribed, should be ordered to any patient rather than going for the total T4, because it is only the free T4 which acts on the tissues and which has the effect. In case of the thyrotoxicosis, where there is increase in the thyroid production, the TSH goes down, followed by increase in the T4, then T3. In the cases of T3 toxicosis, the T3 goes first, rises in the level first, followed by the T4. And in cases of thyrotoxicosis, the ideal test to be done, T3, free T4 in TSH. We do not order the free T4 because of the less labile SS for the free T3. Now there is a variation, and it is important to know when should be the test be ordered, because there is a diurnal variations in the TSH level. They are high in the 12 a.m. to 4 a.m. and they goes down between 10 to 4 p.m. So whether it should be ordered in the evening or in the early morning, this is a question. If we see there is a diurnal variation about 40 to 50%, but if we see the biological, it is around 1,000 in between the lowest and the upper limit. So it won't make any difference. There is no definite timing that TSS should be ordered either in the morning or in the evening. It can be done at any time of the day. And there is an intra-individual variation of 0.5 milliunit per liter, and individual between the two patients of the euthyroid, they can have the variability of 2.5 milliinternational unit. So if we are ordering, TSH can be done at any time of the day, but we have to make it sure that pre T4, it should be ordered before the intake of the medicine, because the free T4 will come in the blood and it will falsely elevate the free T4 levels. Now, TSH, if we see there is a huge surge of the TSH just after the birth because of the temperature difference. Inside the uterus, baby is in cold temperature, and when the baby is delivered, he exposed to a warm temperature. So, within this shift of the temperature, the TSH plays a very important role because it helps in the thermogenesis of the baby. And if we see that during the birth, it is like up to 60 or 70 international, then further with the postnatal time, it falls down. So for the estimation of the TSH, we can either collect the sample by the cord blood, but the ideal time to get the TSH done is on the day 3. But if due to any cause or due to early discharge, it is to be done in between before day 3, then we have to keep the TSH level more than the upper limit, that is around 34 or something. the higher cutoff should be made if it is done before the day 3. So there are certain TSH, this upper limits where we have to take action. Like it is very easy to learn that in the first week it is 40, in the second it is 20, in the second 2 week to 1 year it is 10, and we in the adults and in the children we keep the upper limit of 4.5, and we only treat the patient when the TSH level is above 10. So it has. I have already discussed it that free T4 and TSH has a log linear relationship. It means when the FT4 goes down, the TSH will increase. And in the conditions where FT4 is low and TSH is high, that is above 20, this will be in the case of primary hypothyroidism. And where the free T4 is low and TSH is below 20, then this will be the condition of central hypothyroidism. And in the cases where free T4 is high and TSH is undetectable, then this is the case of thyrotoxicosis. And in the presence of high FT4 and detectable TSH, then this is the condition of TSH adenoma, and it is very rarely found in children. Now, coming to the interpretation, because once we have ordered the investigation and we get the result, it is important how to interpret, because here is the most common mistakes have been done during interpretations by the usual physicians. So this is a very precise table and easy to learn. And if we see that if the TSH is low, FT4 is low, and FT3, all three are low, then it is a condition of central hypothyroidism. But if it could be, FT3 could be normal in central hypothyroidism. And if we see FT3 is high in the conditions where T3 treatment is used, that is the Lenormand treatment, we can find low TSH, low FT4, and high T3. In the reverse, in the cases of thyrotoxicosis, the TSH is low, the free T4 is high, and we'll find the high free T3. In the cases of T3 toxicosis, that is found in the iodine deficiency state endemic areas. In these areas, the patients have low TSH, normal free T4, and the high T3. This is the T3 toxicosis. It has to be remembered. So estimation of T3 becomes important in the cases of this T3 treatment, T3 toxicosis, and thyrotoxicosis. When the TSH is normal and FT4 is high and FT3 is also high, it could be in the TSH adenoma or resistance to TSH hormone. And if the TSH is normal, FT4 is low, and FT3 is also low, then this is the condition of central hypothyroidism. And if we see the TSH is high and FT34 and FT4 both are normal, then this is the subclinical hypothyroidism. And if TSH is high and both the FT34 is low, then this is the condition of overt hypothyroidism that is most commonly dealt with us. Now coming to the neonatal screening, which has to be done in day 3, and TSH has to be taken by the blood sample. It is very important to do this neonatal screening in each and every child delivered in the hospital or outside. And there are certain conditions where we have to rescreen the TSH after 3 days. That is prematurity and the child with trisomy 21, the same-sex twin, and those child who have been hospitalized previously. So coming to the neonatal screening, the serum TSH is twice of the whole blood TSH. So it doesn't matter whether we take TSH, serum TSH or whole blood TSH. Now, if we see the cutoff, if the TSH is more than 40, then we have to repeat the FT4 by the dynamic equilibrium method, and we should start the treatment. And if it is less than 20, or if it is between 34, if it is blood is taken between 24 to 48 hours, then no treatment is required in 99.9% of the cases. But if the TSH is between 20 to 40, then definitely we have to repeat the TSH after 14 days of life. After 14 days, if it is more than 20, then again we have to reassess the FT4 and start the treatment. If it is less than 10, then no treatment is required at all. And if we are in the midway, that is between 10 to 20, then again we have to repeat the treatment after 21 days. We cannot start the treatment immediately. And after 21 days, there are conditions where the TSH is more than 20, then we have to treat the patient. And if it is less than 6, then definitely no treatment is required. And if it is between 6 to 20, this is a very dicey condition, whether to start the treatment or not. So it is better to start than do further investigation. So get the free T4 done in these cases. Scan the patient for the this anatomy of the thyroid, because in the cases of hemigenesis, this 6 to 20 TSH is found very commonly, and we have to treat these patients. Now, thyroid screening in preterm is very important, and it is important to understand because it has to be done between day 2 to day 4. And if TSH is less than 10, then we have to repeat the TSH level at around 2 to 4 weeks when the baby becomes term. And if it is more than 10, then get the free T4 and TSH done. And if free T4 is low and TSH is more than 10, then definitely we have to consider it as primary congenital hypothyroidism, treat the patient. And if the free T4 is normal and TSH is less than 10, then again we have to reassess the child after 2 to 4 weeks or when the child becomes term. And if the TSH is less than 10 and free T4 is low, then we got the confusion. So we have to see either the child is presented with any MPHD features like hypoglycemia, micropenis, and if yes, then consider it as a central congenital hypothyroidism and get the MRI done, immediately start the treatment. And if there are no features, then reassess the FT4. And if it is normal, then repeat the test. And if it is low, then consider it as a central congenital hypothyroidism. Now, coming to after interpretation of thyroid function test, now coming to the imaging. Thyroid scan is important, and we should know when should we go for it because it is quite costly and it is not available in most of the centers. So, if we see thyroid in the different location, that is between the normal location of the thyroid and at the base of the tongue, definitely it is an ectopic thyroid. And if there is an increased uptake of in the scan, then this is could be due to dysharmogenesis or iodine deficiency. And if we find there is no uptake in the scan, then definitely we should go for the thyroid ultrasound. Because if in ultrasound there is no thyroid, then definitely it is a case of agenesis. But if in the ultrasound it is present, then we have to keep our eyes and ear open and we should get the trap antibodies done. If the trap antibodies are present in the child, then this uptake is absent because of the transfer of blocking maternal antibodies to the child and they have blocked the receptors. But if the trap antibodies are negative, then the sodium importer defect and the thyroid receptor defect could be the cause. Now, I would like to invite Dr. Nimesha to start the case scenarios.
So, Dr. Nimisha, you can start the cases.
Thank you, sir and ma'am. We will start with the first case. 20-year-old girl presented with a complaint of with neonatal screening being done with high level of TSH of 28. What will be our plan, Dr. Rajiv, sir?
So now we have done the TSH of a child very early. In fact, we have learned earlier, as what has been taught in these previous 15-20 minutes, that the TSH should ideally be done in a child who is at least 72 hours of age. Now, what happens is because of the birth process itself, the TRH is released and the TSH goes high, and which generally stabilizes by 72 hours. So either we have to have, if at all the child is being discharged from the hospital in early age, say 24, 48 hours, then we'll have to have a higher cutoff levels to see if that is relevant in this particular child or not. And that relevant level becomes around 34 units. If at all, one has to take it into consideration for practical purposes. If that is not the case, a repeat TSH has to be done in these children at 72 hours and then subsequently at 14 days of age. If the levels are still high, then is a time that we have to think that this child may be suffering from congenital hypothyroidism and we need treatment. So we need to repeat the test. And in this particular child, the TSH at 72 hours came down to 8 mu per liter and an FT4 of 1.8, which suggests that this child didn't need any further evaluation or treatment. So the key message is that we need to screen them after 72 hours. And the TSH, if at all, one has to take a TSH levels of 34 in case you do an early evaluation. I can't hear you. You're not audible. Dr. Sab, you are not audible.
Is it audible now?
Yes, sir. Yes, sir.
Okay, sure.
Thank you, sir. Very rightly said. Due to TSH surge, we should do the screening at 72 hours. Moving on to the next question. Day 4 old child with TSH levels of 22. The repeat screening was done at day 14. Again, the TSH was high of 12. At repeat screening done at day 21, the TSH is still high, but the FT4 level comes to be the normal. Dr. Balaji, sir, how would you like to proceed this case?
Thank you, Ma. Thank you for this. So here, as per the screening results, we have the criteria which we were discussing. So at day 3 of life, if it had been 40, we are going to treat. If it is less than 20, we are not going to give any treatment. But in our child, it came out to be 22. So it's like the cat on the wall. It is not more than 40 and it's not less than 20. So at day 3, if such a scenario, we have to repeat again the values at 2 weeks. So again, we repeated the value. So at 2 weeks, if it is more than 20, we are going to treat. If it is less than 10, we are not going to treat. We are going to say it's normal. But in our child, in our baby, again, it is the cat on the wall story. It is 12. So we have to again repeat after 21 days. So we repeated it again. So by 3 weeks, if it is more than 20, then again we are going to treat. And if it is normalizing to less than 6, we are not going to treat. We are going to accept it as normal. But again, in this scenario, it is again, it's 9. So even after 3 weeks of repeated investigation, the TSH is not reducing to normal. So this scenario, something is causing the TSH to remain elevated. So we have to evaluate and see whether it could be hemiagenesis or ectopic. And so nuclear scan we have to do. And we did, and it came out to be hemiagenesis.
Yes, sir. What will be the key messages?
So here the key message is persistence of TSH beyond 6 to 20, even after 3 weeks, is a cause of concern, and we need to evaluate, especially if there is hemiagenesis or not. We have to see and manage accordingly.
Thank you.
T4 is normal. Thank you.
Moving to the next case, day 10 child with TSH of more than 100. FT4 was done, it was low. Scan showed no thyroid tissue. What will be the plan? Dr. Rashmi, ma'am.
Thank you, Dr. Nimisha. Actually, it's a 10-day-old child with the TSH very much elevated, and free T4 is also low. So we have to just it's a straightforward congenital hypothyroidism. We have to start levothyroxine as soon as possible without wasting time, because after 2 weeks of age, there'll be a loss of IQ points for every single minute of delay also. So the drug of choice would be levothyroxine, and there is no role for T3 as such, and it's always prescribed in tablet formulation, because syrup formulation may be unstable. And generally, the dose considered is 10 to 15 microgram per kg per day, but still, again, it depends upon the free T4 levels basically. So lower the free T4 levels, higher the dose should be considered. And the timing of the medication should be at least 4 hours after the feed for proper absorption. Actually, based on the free T4 levels, in this case, the free T4 level is 11. So we can start at a dose of 8 to 10 microgram per kg per day. And if it were to be lower, then we would start at a higher dose. And the free T4 levels need to be monitored on a regular basis to titrate the dose.
Yes, ma'am. On follow-up, there was high free T4 levels, and the dose of thyroxine was reduced, and child was eventually made off treatment.
Here actually, on repeated follow-ups, we have observed that free T4 levels have been becoming normal or even becoming high. So the dose also was reduced, and eventually it ended up in not requiring any treatment. So probably here we have to consider what could it be a transient hypothyroidism should be considered. And even though thyroid scan did not show any uptake, it may be important to do a thyroid ultrasound, because there could be an aberrant thyroid. So if there is no thyroid gland found at all, then we could consider agenesis. Suppose the thyroid gland is found, but there is no uptake, then we must consider TRAB antibodies. And if the TRAB antibodies are present, then probably it's the transient hypothyroidism due to the transmission of maternal antibodies through the placenta. And if the TRAB antibodies are absent, then we may have to consider other conditions. So the most important key message in this case would be just basing our decision on the report of a scan would not be sufficient. We'll have to go ahead with a thyroid ultrasound to check whether there's really a gland or not. And if it is so, then we have to check for any antibodies, thyroid receptor antibodies. So the carry-home message would be, in all cases, whenever there's doubt, to do an ultrasound of thyroid.
Thank you, ma'am. Moving on to the next case, a day 4-old child with TSH of more than 100. On scan, it was found to be dysharmonogenesis, was started on a thyroxine of 50 microgram. On repeat testing at 4 weeks, free T4 was 21 on the higher side, and the TSH was still on the high, free T4 on the normal range and TSH on the higher side. How will you like to approach this case, Dr. Sonal, ma'am?
Thank you very much, Dr. Nimisha. As a child was on day 4 with TSH of more than 100, so it is definitely a case of hypothyroidism, and we have started the right drug in the right dosage. And now, after 4 weeks, we have repeated the thyroid hormone, thyroid test, and TSH is more than, TSH is 20 and FT4 is 21, which is normal, within normal limit, but TSH is at a little bit higher limit. Next, please. Yeah. So usually the dose titration should be done around 2 weeks, 4 weeks, or 6 weeks after the appropriate testing. And as we have tested after 4 weeks, the FT4, our target is around it should be around 1.4 to 2.3. Here it is normal, and TSH, our target is 0.5 to 2.0 mU per liter. Now, we have to interpret both, because initially it takes time for the hypothalamic pituitary axis to get normalized. So it is to becomes reset phenomenon is there. So accordingly, in initial doses, we have to titrate the dose of the thyroxine with the help of the FT4 level, rather looking to the TSH level. Now, if we see the TSH level, if it is high, as it is there in this case, and the FT4 level is low, then you have to increase the dose. But in this case, the FT4 level is normal or FT4 level is high. So if it is normal or high, then you have to continue the same dose. So in this child, we have to continue the same dose, and initially for few months, we have to titrate the dose according to the FT4 level rather than the TSH level. We with TSH level, we normally monitor the level. In this case, if the patient's TSH level is normal, FT4 level is normal, then you have to continue the same dose. But if the FT4 level is high, then again you have to continue the same dose. But if TSH level is normal and FT4 level is high or normal, then you have to reduce the dose. So basically, we have to titrate the dose of the thyroxine according to our FT4 level in the initial phases of the treatment.
Okay, rightly said, ma'am. It is due to the reset axis that TSH was high. So we'll continue with this.
So we continue with the same dose. Okay.
At
Now the
either
same
the-
child, we assess the development of the child, and if the child has presented with a delayed speech at the age of 3 years. So whenever any patients of congenital hypothyroidism, of course, if we have started the treatment in time, we expect the normal development of the child, but there are different associations with the hypothyroidism. So hearing assessment must be done even in the neonatal period or early infantile period, because this may be association of the Pendrit syndrome may be there, which is commonly associated with a hearing loss deficit with the congenital hypothyroidism. It may be there. Okay, so we have to do the hearing assessment in this child to rule out the Pendrit syndrome.
Key messages you will like to give, ma'am?
Yeah. So key message is that because of the hypothalamo-pituitary axis reset mechanism, we have to monitor the FT4 level rather than the TSH in the early phase of the treatment. With the free T4 level, and hearing assessment is must in each and every case of the congenital hypothyroidism.
Thank you, ma'am. Moving on to the next case, 32-week-old neonate was on routine screening found to have TSH of 7 and normal free T4 levels. Dr. Rajiv, sir, how will you like to proceed with this case?
So in a preemie, the TSH may take time to stabilize, and so in that situation, we need to repeat the TSH level in these children at around say maybe 2 weeks of age, and or maybe when they are term, if they are preterm and nearing the term. So only at that time we'll be very sure that this child needs any further evaluation or not. So one has to be very clear and very careful whenever they are evaluating a child who is a premature baby. So day 14, at day 14, this TSH was 14 MU per liter. So this is definitely on the higher side. And there is a delayed rise, so we need to be very careful and we need to reevaluate.
So key messages you will like to give, sir?
Delayed rise and preterm is seen for TSH levels, and repeat screen at 2 weeks and return is needed in these children.
Thank you, sir.
Thank you, Nimisha. So we should always keep hypothyroidism as a diagnosis in the cases of growth failure, where the patients present with the pubertal disorders, either early or the late puberty. Sometimes just looking at the X-ray, we can think of a diagnosis of hypothyroidism if we find a cardiomegaly in the X-ray, and if the patient present with a lethargy, weakness, and on the blood investigation we found hyponatremia, then it could be due to the hypothyroidism. Any motor delay, and where the patient present with the increased acne, increased hair growth, like hypoandrogenism, then always think of hypothyroidism. So these patient may present with very subtle symptoms like fatigability, lethargy, worsening of school performance, and mood swings or emotional lability. The other investigations that give us a clue to the hypothyroidism is presence of high LDL, low HDL, high CPK level, high prolactin, because the TRH increase in TRH also increases the prolactin level. Anemia, it could be both micro and macrocytic. Hyponatremia, this hypothyroidism can present with like SIDH symptoms. And cellular mass, which is basically is due to the pituitary hyperplasia caused by increase in TRH. So coming to the approach to hypothyroidism, before starting, we should always get the free T4 and TSH level done. And I repeat, the free T4 level is important because total T4 won't give us a clue about the effectiveness of the thyroid in the body. So if the free T4 level is low, then get the TSH, then see what are the TSH levels. If it is above 20, then it is the primary hypothyroidism. And if it is below 20, then it is the central hypothyroidism. We should get the cortisol level done and the MRI done in these patients. And if the free T4 is within the normal limit and TSH is below 6, then it is normal. There is no need of any treatment. And if it is more than 10, then treat the patient like a primary hypothyroidism. And if the TSH is between 6 to 10, then look for the risk factors, that is presence of TPO antibody, goiter in the patient, if there is a family history of thyroid disorders in the patient, and if the child is girl. These all are the risk factors that contribute to the treatment. And if there is no risk factors like TPO negativity, no family history, no goiter, and the patient is boy, then we should follow up these patients. Now, coming to the dose initiation, which is very important, it is in the low 1 to 3 years, like in the very young child, we start with the low dose of we start with a high dose of 4 to 6 microgram per kg per day. Between 3 to 10 years, we start with 3 to 5. And more than 10 years, we further lower the dose of initiation, that is 2 to 4 microgram per kg per day. And in the adult, there is a uniform dose, that is, we start with the 1.6 microgram per kg per day, and then we follow up the patient and then titrate accordingly. This we can also use 100 microgram per meter square per day for the calculation of starting dose. And we should start with the lower dose in the patient with subclinical hypothyroidism which present with low FT4, normal FT4 and low FT4 and normal TSH. And in the severe cases, we should also start with the lower doses, because when we start with the high doses, they increase the intracranial pressure and the patient will present with headaches. So we should start with the lower doses in these patients. And always counsel and ask for the patients always counsel the patient not to take any calcium or iron supplements along with or just after or just before the thyroxine medicine, because they will interfere with the absorption of the thyroxine. And also the soy protein, soya beans, soya chunks, they would also interfere with the absorption of the thyroxine. And always counsel the patient that they should not take out the medicine and keep it out of the bottle, because if you have noticed that the bottles are always brown colored glass bottles, or they are plastic bottles, because they are very vulnerable to decomposition after they are exposed to the sunlight. So they should be protected from the sunlight. So coming to the case 6, and I would like Nimisha to go further.
Thank you, ma'am. Starting with the case, 12-year-old girl with obesity, with height of 156 centimeter and weight of 56 kg, with no clinical features suggestive of thyroid disease. With now on diagnosis, there was on screening investigation being done, the TSH was on higher side of 6.4 and was advised treatment. Dr. Balaji sir, how will you like to proceed with this case?
Thank you, Dr. Nimisha. Actually, it's a very practical issue. Everyone knows that hypothyroidism causes weight gain. So most of them order the thyroid function test, and TSH will be elevated mildly, and many have even started thyroxine for that. But we should understand the pathophysiology behind the obesity and TSH relation. Obesity actually increases the leptin, and this leptin has a role in increasing the TRH and TSH because it's an adaptive mechanism where the body, when it becomes obese, tries to reduce down the weight, tries to spend the energy by activating the hypothalamic pituitary axis, and that's why the TSH is getting activated. So here, raised TSH is actually an effect of obesity rather than being the cause. So unless the TSH is more than 10, just mild elevation around say 6.5. So as in this case, we usually should wait and follow up the child unless there are risk factors. So when it is 6 to 10 and there are risk factors like family history is there, girl child, goiter and TPO positive, otherwise we have to follow up. So only when more than 10, we have to treat in an obese child.
So in this child, there was no goiter and free T4 was in the normal range and TPO was negative. So no treatment was required. What will be the key messages you would like to give, sir?
Yeah, so the key messages is that in obesity, the high TSH is actually the effect rather than the cause of the obesity. So don't treat it as a hypothyroidism, and unless it is not more than 10. If it is below 10, no treatment.
Thank you, sir. Moving on to the next case, 10-year-old girl presented with the complaint of poor concentration. Height was 136, weight was 34 kg. The TSH was within normal range and T4 was on the lower side. How will you like to proceed this case, Dr. Rashmi ma'am?
This is a child with poor concentration, so probably she was evaluated for hypothyroidism. Her anthropometry seems to be normal, and she's euthyroid, and TSH is normal, but T4 is slightly low. But here, actually, T4. While assessing T4, we have to consider a few points that it depends upon so many other factors like thyroid levels of thyroid binding, thyroxine binding globulin, albumin, and thyroxine binding prealbumin. So these levels, these carrier proteins may be affected in certain illnesses. So T4 may not give the actual picture in the child. So it will be ideal to do a free T4 in this case because that is the one which clearly show or gives clarity whether the child is really hypothyroid or not. And in this case, free T4 was done, which was normal. So no treatment is required, and after ruling out autoimmunity, of course. So if here TPO also was negative, so here no treatment is required.
Key messages you will like to give, ma'am?
Yeah, whenever we are in a dilemma, it's always better to do a free T4 along with TSH. And if there is a borderline decrease in the T4 level, it's always important to do or confirm it with free T4 levels.
Yes, ma'am. The TBG level will be decreased in cases like nephrotic syndrome and liver disease. So we have to confirm with free T4 levels. Moving on to the next case, 12-year-old girl presented with lethargy, height of 140 centimeter, weight of 36 kg, free T4 on the lower side, and TSH was 12. Thyroxine was started on this girl. What will be your plan, Dr. Sonal ma'am?
Yeah. 12-year-old girl, because of the lethargy, she might have been evaluated for the hypothyroidism. Here, the free T4 is low and the TSH is high. So definitely we are justified in starting with the thyroxine treatment. Next, please. Yeah. So like whenever we come across the FT4 low and TSH high, it is definitely the hypothyroidism, but we have to differentiate between primary hypothyroidism and central hypothyroidism, because here in this case, the FT4 is low, but TSH, if it is above 20, then only it will confirm that it is a primary hypothyroidism. And if it is below 20, then it is a central hypothyroidism. But why we need to differentiate between primary and central hypothyroidism is that because central hypothyroidism, many times it is associated with a multiple pituitary hormone deficiency. So child might have deficiency of the cortisol. And so in this condition, if the FT4 is low and TSH is below 20, we must do like cortisol level in the child, and we must do MRI also. And if FT4 is high and if the TSH is undetectable, and then it is thyrotoxicosis, and if it is detectable, then it is TSH adenoma. So we must do when the TSH is less than 20, we must, with a low FT4, we have to screen for the cortisol level. And in this child, it is low cortisol level was there, and their MRI was suggestive of empty cella. Next, please.
So we'll start with hydrocortisone.
Yeah, so we start the thyroxine after the hydrocortisone level, because otherwise it will precipitate the adrenal crisis. So like we have to start hydrocortisone before starting the thyroxine.
The key messages, ma'am?
Yeah. The key messages is there that whenever there is a low free T4 level with TSH less than 20, suspect central hypothyroidism, and always do MRI brain and the cortisol levels, and start thyroxine after if the cortisol is low, start thyroxine after hydrocortisone.
Thank you, ma'am.
Yeah.
Moving on to the next case, 12-year-old girl presented with growth failure. TSH was very high, more than 100, and free T4 level were low. Dr. Rajiv, sir, how will you like to proceed with this case?
So this child is around 10 to 12 years of age with growth failure. So unlikely to be having pubertal changes, but still we need to evaluate them for pubertal changes. And then the basic, after evaluation of the bone age and everything, and we need to exclude there is celiac disease or other factors which may be responsible for, along with, we'll have to start treatment in this child. The standard dosages for thyroxine supplementation will be 100 microgram per meter square per day. We need to use very good brands in these children. We have to start with small dosages to begin with and gradually build up. There is no urgency of starting full dosage at the day one. At the same time, we need to explain to the parents that they have to store their medication in a proper manner. They should not take it out and keep the medicine outside. The child should not be taking any calcium supplement or any iron supplement along with the thyroxine supplementation when it's done, preferably in the morning. Empty stomach is probably the best way to do it. They should not be soya proteins or soya shakes or whatever they are taking. And then the dosages, because this child is around 9 to 12 years of age, could be around 3 to 5 microgram per kg per day. So that's what the treatment should be. And we need to then follow up on a regular basis, getting the TSH and FT4 levels done.
Thank you, sir. On follow-up after 1 year, TSH was still high and free T4 was also on the higher side. What will be our plan, Dr. Balaji, sir?
Thank you, Dr. Vignettes. Actually, we titrate during the follow-up based on the T4 and TSH. Due to the feedback relationship, whenever TSH is down, T4 will be high, and whenever T4 is low, TSH will be high. So based on that, we decide. So if the free T4 is low and the TSH is high, which means that we have not suppressed, we have not given properly. So we have to increase the dose. And suppose if the TSH is low and the free T4 is high, then maybe we are over treating. We have to reduce the dose. But here it's a dilemma where TSH is also high and free T4 is also high. One important clue is the half-life of the TSH and T4. Free T4 has a very short half-life, whereas TSH has a large half-life of almost weeks. So in order to suppress the TSH, we need to give treatment properly for weeks together. So the compliance has to be daily for weeks together. But for T4, if they have even taken 2 days or 3 days before, the T4 level might come normal. So whenever we have a scenario where T4 looks normal, but TSH is not suppressed, we have to always check the adherence. So adherence is a very important fact. Or sometimes unknowingly they might have even taken the test after taking the thyroid medications immediately. So we should not do the test immediately after taking the thyroxine tablet. So recent intake of medicine is the cause for the raised FT4. Yeah.
So key messages here will be to
So I think we have to gradually build in a hypothyroid child, gradually replace that. And timing is important. We should do the test without taking the medications, and always check the adherence when T4 appears high and TSH is also high.
Thank you, sir. So we, if both free T4 and TSH is high, we should check on the adherence of the child. Moving on to the next case, 6-year-old boy with his meningitis was admitted in ICU with the meningitis. Here the TSH was low and the free T4 was also low. So how will you like to approach Dr. Rashmi ma'am?
Yeah, this is actually a case of meningitis, basically a sick child. So ideally, thyroid profile shouldn't be done in this situation. But if there's a strong suspicion of some underlying hypothyroidism, probably it was done. And here, this as soon as you see this, it appears as though it is central hypothyroidism because both TSH and free T4 are low. So if we follow this algorithm here, whenever TSH is less than 0.05 milli-international units per liter, it's always good to do a free T4. And if free T4 is found to be high, then it's obvious that it's thyrotoxicosis. And if it is normal, then we have to just follow up. But here the level is in between 0.05 to 0.3, that's 0.1. So here always in a sick child, it's better to do a cortisol level. If the cortisol level is low, then it goes in favor of central hypothyroidism. But in this case, if it is high, then it is normal. Probably there is no hypothyroidism underlying. It is due to the stress because of the illness. And the cortisol level was done here, which was elevated. So here it's obvious that it's a non-thyroid illness, and the transient depletion of the decrease in the TSH and both free T4 and TSH is basically because of the sickness. So it would be good to follow up this child, repeat the thyroid profile after 2 weeks or when the child becomes all right.
Thank you, ma'am. We'll move to the next part of the topic.
Thank you, Nimisha. So moving forward, so always think thyrotoxicosis when a patient present with weight loss, hypodefecation, that is going to washroom after each and every meal, tremors, weakness, and palpitations, eye signs when they found their eyes have become big. Some patients only present with sudden paralysis, that is periodic paralysis, polyuria. So, in these cases, after prescribing the thyroid profile, we should always go for the scan. And remember, if the patient present with goiter or eye sign, and if he or she doesn't present with goiter or eye sign, and if the TSH is low and FT4 is high, then the most common cause is the Graves' disease. Then in these cases, always go for the nuclear. In the cases of Graves' diseases, if we are 100% sure, then the nuclear scan is not compulsory, but where we have a doubt and the patient present with eye signs or goiter, then go for the nuclear scan. And if we see there is an increased uptake, and on the uptake, if we see there is a localized uptake, that is the due to the solitary nodule, and if we see there is a multiple uptakes on the scan, then the diagnosis will be toxic multinodular goiter. And if there is a diffuse uptake, all this isotope is taken by the thyroid gland, then this is the case of Graves' disease. And in cases where there is a decreased uptake and patient present with the pain during swallowing, and if we find there is a tenderness on the examination, then this could be due to the subacute hypothyroiditis. And if there is no pain, no tenderness on the examination, then this could be due to chronic lymphocytic thyroiditis. So, moving forward with the next case, a child, day 12 child presents with the irritability.
Thank you, ma'am. So we'll now see the cases of thyrotoxicosis here. The day 12-old child who presented with irritability. Birth weight was 2.8 kg and now on day 12 it was 2.2 kg. Heart rate was on the higher side. There was proptosis. FT4 levels were very high, 44 picomole per liter, and TSH was suppressed, less than 0.001. There was history of Graves' disease in mother who has been treated with radioactive iodine 2 years ago. How will you like to approach this case, Dr. Sonal, ma'am?
Yeah. So this 12-day-old child has presented with irritability, and there is a definite weight loss of 600 grams, which is abnormal. And the child had high heart rate with the proptosis. So this definitely, and FT4 level very high and the TSH low. So this favors thyrotoxicosis. Here, definitely the like if the and there is a history of mother suffering from the Graves' disease. Now it and the treated with a radioactive iodine also. So if the mother is having Graves' disease and is on anti-thyroid drugs, there are two possibilities which can happen in the child. One thing, it can be because of the transplacental passage of the anti-thyroid hormones. There will be like child may have hypothyroidism, and there will be transplacental passage of the TRAB antibodies also, and the TRAB antibodies, they have a half-life of 2 weeks, so they may present with that is TRAB antibodies is TSH receptor stimulating antibodies. So this, because they can present initially as hypothyroidism, and after 2 weeks they may present with the thyrotoxicosis also, as it has happened in this child. So but this hyperthyrotoxicosis may be transient, and it may be for up to 6 weeks. But this child needs to be treated with anti-thyroid drugs and the beta blockers and steroids and iodine if there is a severe symptoms are there. Next.
The key messages.
So key messages is there whenever there is a tremor and weight loss, as it has occurred in this child, suspect thyrotoxicosis. If there are eye signs, then there are Graves' disease, then it is more likely to be Graves' disease, and treat with the methimazole and the radioactive iodine. Here the catch is that even TRAB antibodies can persist even if the like mother has received radioactive iodine like before the in the past. So TRAB antibodies can persist. So even if the patient has mother has taken the treatment, the thyrotoxicosis can be there in the baby because of the TRAB antibodies.
Thank you, ma'am. So every child with the history of mother having Graves' disease should be screened at the birth.
Yeah.
Moving on to the next case, a 12-year-old girl with weight loss and tremor with FT4 on the higher side and TSH being suppressed. There was thyroid swelling but no eye sign, tremors present. What will be the plan in this case, Dr. Rajiv, sir?
We need to see the other clinical features of hyperthyroidism like hyperdefecation or some form of polyuria, or if as you say there is no eye sign. But in this situation, we'll have to then think of hyperthyroidism in this child. And when you think of hyperthyroidism, the first and foremost important test would be a nuclear imaging of this child. So a nuclear scan need to be done, which might show you either an increased uptake or a decreased uptake. In case there is an increased uptake, if it's a solitary nodule or it's a toxic multinodular goiter or it's a Graves' disease, where it will be a diffuse uptake of the technetium. Of the radionuclide material. But if in that situation it will be Graves' disease, and in case there is a decreased uptake, could be it could be subacute or it could be chronic lymphocytic thyroiditis. These all things need treatment in the form of drugs, so which we have already discussed. I think Madam has already discussed that we need to give them methimazole or radioactive iodine.
This child had on screen
and propranolol, and beta blocker.
So the child was started on treatment with methimazole and beta blocker, and eventually the radioactive iodine treatment can be given. If as per
Yes.
the key messages, sir.
So the key message is that we need to be careful whenever a child who presents with us with tremors and weight loss. We have to have a suspicion if even if the eye signs are not there, and if the eye signs are there, it's very well suggest that it's a grave disease, and the treatment is, as we have already discussed, is methimazole and radioactive iodine and beta blockers.
Thank you, sir. Moving on to the next case, 8-year-old boy with a thyroid swelling, as seen in the picture. Dr. Balaji, sir, how will you like to approach this thyroid swelling?
Yeah, so whenever a child presents with a midline swelling in the, so we have to do the routine examination, check whether it is cystic or not, and whether it is moving with the deglutition or not. And when you protrude your tongue, whether it is moving with the tongue movement or not. So here it is a cystic swelling in the midline, and it is moving on protrusion with the tongue. So it's a thyroglossal cyst, so which is actually an embryological structure formed during the thyroid descent from the base of the tongue. So it's a benign thing, and surgery is the clear-cut option. Yeah.
Thank you, sir. So we'll move to the next case. 10-year-old girl with thyroid nodule, as can be seen in this picture. Child on doing the thyroid function test, it was euthyroid, TPO was negative, and child was reassured and sent back to the home. On follow-up, there was rapid growth seen. Dr. Rashmi ma'am, now how will you treat this patient?
Yeah, whenever a child presents with a swelling of the thyroid, we definitely do a thyroid profile. And in this case, it was normal, and hence probably she was reassured. But a few points we have to keep in mind whenever a child presents with thyroid swelling is we have to check the size. If the size is more than 1 centimeter, and if the swelling is fixed to the underlying structures or surrounding structures, and the associated lymph nodes are significantly enlarged, or if there's a history of any long-term low-dose radiation, or there's a family history of some malignancies or these MEN type of syndromes, then we have to consider, we should definitely rule out malignancy in this case. So FNAC or a biopsy is mandatory in this case.
Thank you, ma'am.
Yeah, thank you.
Thanks a lot, Nimisha. And we have developed multiple tools which help in terms of evaluation of thyroid in the form of approach pathways, in form of interpreters, which are available. And they really help us achieve the right diagnosis. If you just enter the thyroid profile, you will get the results, and interpretation will be there. And they have been shown to substantially improve the concordance there. And we have recently launched a thyroid nodule interpreter, which is also looking into those factors as Dr. Rashmi was talking about. If we are able to assess that, that will be something which will get us the right diagnosis from that regards. So we are coming to the end of the thyroid part. We'll see if there are any particular questions which are there. So if we have low TSH suppressed and normal FT4 and normal FT3, is it subclinical hyperthyroidism? Yes, this will be a subclinical thyrotoxicosis. We will not, so this is some scenario in which we have to be careful in terms of evaluation. We don't generally treat a marginally suppressed TSH in that regard, Dr. Asma. Next question from Dr. Asma is TSH resistant. We give TRT with thyroxine and TSH is not suppressed. So TSH resistance. So TSH resistance is a very unusual scenario in which you will have presentation. The TSH will suppress because the resistance is at TSH level. It's not a resistance at the level of FT4. So FT4 will work. So that will be the scenario from that regards. Dr. Mampi Das is asking indication of thyroid ultrasound in congenital hypothyroidism. So it is basically definitely thyroid ultrasound will play a role. It gives us information about the anatomy of the thyroid, and that could really be helpful in that regards. And if thyroid scan is not available, ultrasound will give us a picture as to how things are and how we are going to proceed from that perspective. Dr. Soumya Mohanty is asking about reset mechanism. So reset mechanism of TSH is basically that if the child had been exposed to severe hypothyroidism in birth, the TSH levels will remain very, very high, and they may take much more time. So they will need a much higher level of FT4 to respond. There is a pituitary hyperplasia. So this is what we call as a reset mechanism of the scenario, and this may last. So that is why for the first 1 to 2 years, we should do both FT4 and TSH. Dr. Khadika is asking congenital hypothyroidism, but since age of 1 year, always high TSH around 15 and normal to high FT4. So this we have to think of whether we are dealing with something else. If FT4 is high and TSH is also high, it may be a form of a thyroid hormone resistance. So we have to think of that possibility in that regards. Dr. Munir asking if non-thyroidal illness suspected cortisol is not high, should this exclude NTI? Very, very good point. So if you have a non-thyroidal illness, one of the reasons why your TSH is low is because of high cortisol. So if you have a severe enough stress to cause non-thyroidal illness, cortisol has to be high. So I always use cortisol as a good marker in that regards. Dr. Rajesh TV is asking for breastfeeding, how much time we have to wait after thyroxine. Generally, it's difficult to control in the newborn period, but we say if you have 3 to 4 hours prior to the medicine and maybe half an hour after that, that should be fine. Dr. Dhruv Agarwal is asking 4-day-old newborn with normal TSH but low T4. Should we do FT4 or can we start thyroxine directly? No. This is a very, very scenario in which you have to be very, very cautious. We should do a FT4. If FT4 is low and TSH is normal, we should do a central screen, look for micropenis, midline defect, hypoglycemia, MRI, cortisol, and then start treatment. Dr. Kaushik is asking about when to start treatment for subclinical hypothyroidism. So generally, we do not start routinely unless there is a large goiter, unless there is a TPO antibody which is positive, unless there is a strong family history, and very, very rarely if somebody has had a late effect of cancer therapy. That scenario, we have to start treatment because TSH is a tumorogenic hormone which we want to avoid in that regards. So